We present you an instructional video for the treatment of the posterior root of the lateral meniscus. Patient 40 years after torsion trauma, 3 weeks in rehabilitation program. Symptoms of damage are also visible on MRI marked with the arrows, damaged posterior root of the lateral meniscus. A very artistic trauma of damaged meniscus and anterior cruciate ligament, ACL. The patient typically in anesthesia. The first step is to place good portal in the knee joint. Access with the trocar from the lateral side. Camera head in the knee joint. The first part of the procedure is arthroscopic diagnostic. We look at the patellofemoral joint, the medial compartment, the lateral annulation and the anterior part of the knee. We need to place the medial portal. Prop the medial access, medial compartment. Visible meniscus, medial, undamaged, stable. The femoral condyle cartilage and the tibia plateau also normal. Damaged ACL is visible in the anterior compartment. In the lateral compartment, we can see the detached part of the posterior root of the lateral meniscus covered with the newly formed scars from the hematoma. First, the bridgement and checking with a hook whether there is also any other damage. The next step after the surgical access incision is performed on the medial side of the tibia. At the level of the footprint, we put a drilling offset into the tunnel so that the hole in the knee joint is the place of the native root of the meniscus to the bone. We can see distal part of the ruptured ACL and distal part of the PCL. First, we drill with the passing K-wire. After drilling, we remove the offset and place a bone spoon on the end of the wire, which we can see in arthroscopy. We need to do this to make sure not to damage the structures in the knee joint by drilling, especially so that the wire cannot move to the popliteal fossa, damaging important vascular nerve structures. We drill the tunnel with a 4.5 cm drill. Then we insert the guide monofilament into the tunnel. Then we use a manipulator to pull out the monofilament suture. Instrument for stabilization Firstpass Mini, there's 3 types: stride, turn right and turn left. In this case we use a stride Firstpass Mini. We use it from the lateral portal, keeping the camera heads in the medial portal. We put on the first suture. We use the ultra tape to stabilize better the meniscal root. In the chronic lesion, the tissue is not of good quality and regular sutures may cut it. The tape stabilizes the tissue better. To be sure, we put on a double suture so that the damaged tissue are attached better to the bone. We put all the tapes through the loops and pull them through the channel. Make sure that the tapes are in the same channel with the guide threads and are not separated by any soft tissue bridges. If you are sure that they pass through the tunnel, we drag them and tighten the meniscus root. There are 2 options for good stabilization. One of them is to use the end button. I prefer the second one, stabilization with the footprint anchor. In this case, we will use 2 footprint anchors because the tapes are thicker and you want to be sure that the seams stabilized properly. We put on footprint according to the technique. First, prepare the appropriate hole, then tap anchors, keeping the tension. Tapes screw internal part of the anchor. Once again, just to remind you, first you create the hole for the anchor. We pull the suture through the anchor. Tighten. The assist controls the tension. Stick the footprint to the bone. And then stabilize it by turning the pressure screw according to the technique. The visible meniscus is stable in the tunnel and well attached. this is where the procedure ends. Thank you very much.